Hello, everybody. Welcome to a new episode of the Dissenter. I'm your host, as always, Ricardo Lopes, and today I'm joined by Dr. Laurence Kirmayer. He is James McGill Professor and Director of the Division of Social and Transcultural Psychiatry at McGill University and Editor-in-Chief Emeritus of Transcultural Psychiatry. He also directs the Culture and Mental Health Research Unit at the Jewish General Hospital, where he conducts research on the mental health of Aboriginal peoples, mental health services for immigrants and refugees, and the cultural basis of psychiatric theory and practice. And today we're going to focus mostly on one of his edited books, Cultural Consultation, Encountering the Other in Mental Health Care. So, Dr. Kirmayer, welcome to the show. It's a huge pleasure to everyone.
Thank you. It's a pleasure and a privilege for me to be here.
Thank you. So, let's start perhaps with a question just to set the stage for the rest of the conversation. What is cultural psychiatry? Because, of course, we all hear about psychiatry in general, but with what kinds of questions does cultural psychiatry deal with?
Well, I think cultural psychiatry stems from the recognition that there's significant variation in how people experience and express psychological or psychiatric problems, and the ways they interpret those problems and the ways they try to cope with them or deal with them. And those differences are important in addressing care, but maybe they point to deeper insights into the nature of human suffering and healthy functioning. So cultural psychiatry tries to put that question of cultural variation at the center of research and theory and practice in psychiatry.
Mhm. And taking into account what you just mentioned, particularly cultural variation, why is cultural diversity a challenge to mental health care, particularly, of course, in multicultural societies?
Well, I think it's a challenge on a global scale for a number of reasons. First off, the frameworks that we use in psychology and psychiatry largely emerge from a fairly narrow range of cultural contexts, Northern, Western, European, North American traditions, that while they're very internally diverse, really represent a small segment of the wide variation in ways of life and belief systems and daily practices and so on around the world. And if those variations have impacts on child development, on the nature of symptoms and suffering, on how people deal with everyday problems and more severe challenges, then somehow we have to take those into account. In particular, if people interpret their problems in particular ways that may not conform to the expectations of biomedicine, cosmopolitan medicine, psychiatry, and so on, then there's going to be a disjunction, a breakdown in communication between what people think is going on, what they think they need, and what's on offer in conventional psychiatric care. Maybe that's a good thing. Maybe people will just go somewhere else and get what they actually need. But we know on a global scale there are many people who are suffering from, severe problems that are cause them a lot of suffering, that cause impairment, and don't always find what they need. And we do think that psychology, psychiatry, social work, all the range of sort of mental health disciplines have some things to offer in that context. So the question of how to translate what we have to offer into meaningful terms for people that they can make use of, how to, in the other direction, how to understand what they're presenting in a way that lets us respond appropriately is pretty central. In fact, cultural psychiatry, or transcultural psychiatry as it was called originally, really developed to a large extent at McGill in the 1950s because people were coming to McGill to train from different parts of the world, from East Africa, from Asia, and so on, and they raised questions about how well what they were learning would actually fit the typical person that they would see in a clinical setting in their countries. So rather than just viewing that as a kind of knowledge translation problem where people simply need to be educated to understand what's good for them, it was seen as an opportunity to learn from human variation more about the nature of mental health problems and also about how to provide something that's genuinely useful to people in context.
And please correct me if I'm wrong, but because of the fact that I've already also talked with many anthropologists on the show, I would imagine that when it comes to psychiatry and psychiatric practice specifically, people also have to take into account that if different people come from different backgrounds, there might also be the risk sometimes of over pathologizing certain behaviors and certain aspects of people's psychology, because certain things that in our own cultural or in our own society might not be considered normal or normative in other cultural contexts are perfectly normal and adaptive behaviors. Correct.
Yeah, so certainly there are differences in what is viewed as unusual or problematic, outside the norm in different places. That problem occurs in North America or in European societies, even with people who were born in that place, either because of cultural differences or subcultural differences, people coming from a rural area, let's say, or with different kind of educational background or whatever. There can be differences in how people present themselves that lead to misdiagnosis. A famous example from the US is the tendency to underdiagnose mood problems and overdiagnose psychosis among racialized groups, particularly Black people, because of certain cultural stereotypes. So this is not only what we're talking about, a function of the cultural beliefs or way of life or experience of the patient, but also the assumptions, the framework that the clinician is using, and the implicit norms that they have for how a person should be expressing concern. So, for example, in a racist society, to be suspicious and concerned and mistrustful is an adaptive, appropriate response for people who, are in power and may be quite insensitive to the everyday struggles that you face. And that could be misinterpreted in a clinical setting as somebody being inappropriately suspicious and therefore paranoid. So that's a common dilemma, as I say, within the same society with people who've lived together side by side for hundreds of years even, but who occupy very different positions in society and have different experiences as a result. I should say the opposite can happen. That is to say, people can have problems that we don't recognize because we don't know what is really important to them. The failure to perform a certain aspect of a social role that we think, well, that's not so important, might be absolutely vital to someone, and that might be a source of distress. So I think in every case, we want to understand the person's problems vis-a-vis their own social and world, their own cultural context, and their aspirations. What is it they're trying to move toward in their life? And that's what we're trying to calibrate. It's actually unusual, though, that somebody, let's say, would be completely misdiagnosed as having a problem when they don't, simply because, in most parts of the world anyway, simply because most people don't come to psychiatry unless they're having a very hard time and are being disruptive in their lives or failing in their social roles or in some other way other people around them are getting alarmed. So usually there's at least that very rough distinction that something's wrong, but how to characterize it and how to approach it, I think, remains something that requires a lot of care.
And another thing I would like to ask you about, and perhaps we will come back to this point also later on in the interview, but when it comes particularly to migrants, of course, when we move to a new society or a new cultural context, we have to adapt a little bit our behavior to the local norms, local rules, and all of that. So is cultural psychiatry, or do you think the psychiatric setting is also a good place to help people deal with that or not? To
Well,
deal with their
yeah.
basically their integration, let's say.
Yeah. Well, migration is a big topic, and I guess the first thing to say about it is, human beings are a migrant species. We all presumably came out of Africa, and we have certain, biological readiness to move and to adapt and to learn new things and to refashion our niche in a way that we can survive. So in and of itself, other things being equal and having adequate resources, I don't think migration itself is necessarily a huge mental health strain, let's say, or stressor on people's lives. It's a challenge, in other words, that we're equipped to deal with. Having said that, there are many ways to migrate. And if I decide, I'm moving to England because I'm excited to take a new job somewhere, I'm moving to a place where I know the language, where I have an appearance that will let me blend in, where there are many, many things, and maybe I'm going toward a job that will confer on me certain prestige, and so on and so forth. That's very different, let's say, than moving to England from an equatorial region, from a former colony, being a person of color, experiencing an environment where you have everyday sort of racist and derogatory kinds of interactions with people. All of that is going to be a very different kind of a change, a very different environment to adapt to, and it will take its toll on many people. Or to take a very common example at this moment in time, if I'm forced to move because my country's descending into war, or there've been terrible natural catastrophes, and there's no way for me to survive, then I may be fleeing literally for my life with nothing but the clothes on my back, and going to a situation where I'm in extreme precarity at that point. I may not have official status. I may not know if I'm going to be allowed to stay. I may not have access to work, I may be leaving behind loved ones who I'm frightened of. All those things become the burden and the challenge that I'm facing. So migration is not one thing, and as I say, by itself, the barest kind of possibility of moving to something new. People do this all the time for advancement, for entertainment, for all kinds of things. So it's not inherently a problem. It's all of these disparities, all of these extra burdens that get put in place. And I guess one of the big implications of that for us is to realize that when we talk about migrant mental health, which is definitely one big strand in the discussion in cultural psychiatry, it's not only about the migrant, it's about the receiving society. Because if I go to a place that says, fine, you're here, we welcome you, we've had some examples in Canada where there's been a government plan to receive a certain number of people from Kosovo or from other places, and then there's been, or the Ukraine right now, and then there's been a very deliberate welcoming and warm reception and path for people to get their kids into school, to get jobs, et cetera, et cetera. So those are the more optimal kinds of transitions, and you're not going to see as many problems. People may still have a sense of loss and nostalgia and feelings of exile and other things that are hard to deal with psychologically, but it's nothing like what they're going to experience if they're forced to move and have a extended situation of uncertainty, of precarity, and an inability to rebuild their lives because not only because of their own personal challenges, but because the receiving society is not really offering them a scaffolding or a path to rebuild their lives. So as in many of the, this will come out as we continue talking about culture. I mean, culture is something that resides in people's own upbringing and the worlds they live in, but it's also something as such that's created at the interface between people who have different experiences. So the status of being a migrant, takes on a particular meaning, not just because of what your past is, but because of what situation are you in now, and how are people looking at you, and what identities are they ascribing to you, and so on. So it's this in-between that we're trying to help people negotiate.
Mm-hmm. When it comes to addressing diversity in mental health services, how do you approach it? Are there different approaches out there that people can resort to? Is there only one that is considered the best? How does it work exactly?
Well, I think there are many different approaches. Years ago, I wrote a paper with an Australian cultural psychiatrist, Harry Menas, comparing the approaches in several countries that were all relatively wealthy, had highly developed healthcare systems, and so they had their own traditions, for that matter, of psychiatry, psychology, social sciences. So they had all the resources to sort of think through the problem, and yet they approached the question of cultural difference and diversity of mental health in different ways. So, for example, first of all, I would say that the most common situation worldwide is to ignore the difference and pretend that everything will work fine, or to make the assumption that since people are newcomers, or since they represent a minority or something, that they should make the effort to learn what the right way is to understand their problems, talk about them, make use of services. So that's the kind of degree zero kind of, no adaptation, just get with the program. We expect you to fit in kind of in some ways. And we have evidence that doesn't always work, that leads to problems, as I say, even within societies where it's not newcomers, it's people who are well-established part of the society, but who have, different orientations, different views. The sort of next level, I would say, is educating people. So then there's this idea, okay, so people are not necessarily always picking it up. So let's go out and tell people, here's what it's like. So for example, in most parts of the world, psychiatry is really only for people who are severely mentally ill. People who really are having psychotic illness or something that's very, very disruptive to their lives, and it's obvious to people around them something's wrong, and they end up, with family and people around them searching for some kind of help. The very, very broad umbrella of things that we put mental health under and include psychiatry and psychology and other things, sort of, we see similar patients in North America and so on. So that includes, a college student who says, I don't know what to do with my life. Or I'm having trouble in my relationships, or just, the everyday problems that virtually every person has at some point in their life. That's included in psychiatry. So we see this huge, broad spectrum, but that's not the experience of people in most parts of the world. So kind of psychoeducational approach might be to tell people, look, what we're calling psychiatry means many, many different things. It doesn't mean that you're a mad person. It doesn't mean that you have this severe, severe problem. It's just maybe you're having existential issues, and this is a group of helpers who could maybe have something to offer. Or maybe you're having a lot of anxiety and learning some relaxation or taking some kind of some medication or something that could be helpful. So it's this educating people how to be better consumers, if you will, of existing resources. So that's the next level. The third level, I would say, and there's nothing special about these levels, but just distinguishing the extent to which we can sort of take the cultural difference seriously. The next sort of level of engagement is to recognize that people do have different languages. Literally, they have different languages. Sometimes they have different idioms. And so we need to be able to bridge that language. So a lot of our work that we do with migrants, interpreters, mental health interpreters are very, very important. Too often we're in a situation where, for reasons of expediency, people will be asked to use whatever level of language they have to communicate their distress and get some help, but often that leads to breakdowns in communication. And because we're not just talking about language, although language is perhaps the most powerful and profound aspect of culture for people, but culture includes lots of nonverbal things, lots of material arrangements, lots of other things. So we often use not only interpreters, but also culture brokers. And so culture brokers are people who have some knowledge of the two cultures that we're trying to bridge, and they can broker communication, facilitate communication back and forth, in a sense, by helping to translate not literally the words, but the missing context that it takes to understand what a person's saying. So we might have an interview with somebody who comes from an area where the medical establishment is working with oppressive political authorities, and we don't know that. And so there's a failure of trust again in the medical situation. It's very helpful for the clinician to know, oh, this person may not feel at ease with you because you're wearing a white coat, but they were in a situation where people wearing white coats were torturing them, or something else extreme. So that kind of sharing of information, which goes in both directions, it can be turning to the patient or the client and saying, what you need to know to understand what the doctor's saying is so and so. Here in Canada, or here in London, or here in Spain, this is how we do things. That kind of filling in the context becomes this kind of bridging. So that's the sort of next level. A further level is to say, okay, we've opened some channel of communication. We have linguistic communication. We have some contextual elaboration of the meaning of things, which can occur even when we share the same language, if we come from different backgrounds. But we need to reconsider how we're framing the problem. So we need to adapt our frameworks in some ways. And we have different tools for doing that. One of them is to do a kind of culturally oriented interview, where we try to get at people's own understandings of their problems, how they explain them, what they attribute them to, what the significance is of that explanation, and so on. So that's a kind of cultural adaptation of assessment and ultimately of intervention. And that can be done in different ways. In the US, often that's been approached in the past with the idea of sort of ethnic matching. You're Hispanic, so I will get you a Spanish-speaking therapist, and it'll all be fine. They'll know, Of course, the fact that, you have North, Central, and South America lots of different Spanish-speaking peoples, not to mention Europe, with very different cultures and very different, hybrid things, even different versions of Spanish and so on, so that you can have what apparently looks like, oh, we've made this match, but the match is very crude and even conveys the wrong thing. It even conveys, let's say, an implicit colonial hierarchy or some other thing that you're unaware of as an outsider. You're unaware that this is an important nuance. So that matching, and in the US, that matching became a popular strategy, partly for political reasons, because the US had used these ethno-racial blocks on the census for many years. So they had created the illusion, I guess, demographically, that you had five groups. You had Caucasians, which, is a kind of fictive category, a geographic fictive category, racialized category. African Americans, Asian Americans, and Pacific Islanders, who represent, 2/3 of the population of the world. American Indian Alaska Natives, and what am I leaving? And I guess Hispanic Latino. So you had these very heterogeneous groups that were treated as though these were the groups, so you could have matching at that level. In most other places, those categories don't mean the same thing because demography is different, the histories of migration are different, and so on and so forth. And moreover, even within those groups, even in the US, there's huge variation. So that matching doesn't necessarily work well. And even if you have background knowledge, you have language, obviously is a huge asset if you can speak the language of the person you're trying to help, but you need background knowledge as well. And you might not have that. You might have come from a different social strata, different part of the world, had a different kind of education that has made you more distant and even led you to reject some of the background knowledge that you had at one point, which you need to be employing to make sense of what the person's saying. So that brings us to sort of what for us is the most useful level, which is this kind of cultural formulation process, where we try to understand how does cultural meaning and cultural practices affect people's illness experience. And by that I mean not only the way they express it, but even what the causes are and what the mechanisms are and what the course is going to be. So building up that picture, which we then use to guide both how we assess the problem, how we might describe it, and how we intervene.
Mm-hmm. And since you mentioned race there, I was saving this question for later, but perhaps this is a good point to introduce it. So when it comes to minorities, racial minorities, but not only that, also other ethnicities and even different genders, does the way those categories interact with hierarchies of power matter in a clinical context?
Yeah, well, I think we have lots of evidence at this point, epidemiological evidence, certainly clinical evidence in terms of individual cases, but on a large scale at the level of social determinants of health, we have lots of evidence that it matters a great deal, that there's a lot of suffering associated with having an identity, whether it's one that you've chosen or one that's more commonly been ascribed to you in some ways that maybe doesn't even fit very well with how you actually experience yourself, but that being your primary identity and that being a disvalued identity in the society causes huge problems. And it causes developmental problems for children starting early on. It involves constant cognitive burden for adults as they try to negotiate a world that for them is more dangerous and more fraught and more exhausting in some ways to deal with. And it creates all kinds of complexities internally and interactionally with other people. I've already mentioned the idea that there are diagnostic biases that occur when a person presents who's assigned to a certain racialized category. And to stick with race for a moment, because it's one of the most powerful ones and one of the aspects of identity for which we have lots of evidence how harmful it is. I mean, if you're a black person in the US, you are at much greater risk for high blood pressure. And a good part of that reason, it has to do with everyday exposure to racism. If you're a black person migrating to the UK, you're at significantly greater risk for developing psychosis. And as far as we know, that's also related to exposure to racial discrimination and disadvantage. So there are important things going on in terms of specific kinds of stress. And it's important to emphasize that those identities, like racialized identities, are socially and culturally constructed. They don't have a stable biological basis. because human populations everywhere are one interbreeding population, and people are all intermixed, whether they realize it or not. I mean, in South America, everybody is mestizo, whether they're labeled that or not, virtually everybody to some degree because of who originally arrived and how things unfolded. In Quebec, my colleague Gilles Bibot has said there's not a single Québécois de souche, pure laine, somebody from the original settlers who doesn't have Amerindian blood, because all the original settlers were men. And so, this is the reality, but then we construct categories, and we use, visible cues and other things and histories to assign people to categories that have huge consequences for their everyday life, for how safe they are, whether they, have to teach their children how to interact with the police in such a way that they don't get killed because of moving too quickly in a moment when they're under huge suspicion. I mean, it doesn't take a lot of imagination to see that this is an enormous stressor. I mean, social relationships of solidarity, relationships of friendship, relationships of comfort versus relationships of threat and danger are among the most powerful stressors and sources of well-being, I mean, on the other hand, that human beings have. So if you create an environment that is adverse for people, and adverse not just at one moment in time, but maybe across the whole lifespan, it's to be expected that there are going to be all kinds of consequences, not just mental health consequences, and that a clinician, a healthcare provider, has to be aware of those things if they're going to respond appropriately to the needs of the person in front of them. We're at a moment in North America, probably globally, because of the way in which social media have exposed, some of this violence that occurs on a daily basis, where there's been a bit of consciousness raising, where people are a little bit more aware of just how intense this history of violence is. I recommend this book, Exterminate All the Brutes, that really just gives a bit of the history of European colonialism and how it installed these racialized hierarchies that people are still, struggling with in very profound ways. So we're trying to get psychiatry has been complicit with this to some degree. It was part of the institutional apparatus of colonialism, bringing healthcare and bringing all the resources to people that they need, but doing it in a way that then created certain hierarchies and created identities that are problematic for people. We're all kind of trying to work on this now in some ways to improve the way that we respond to these huge disparities and inequities, both locally in our societies and virtually every society and globally.
Mm-hmm. But when it comes to marginalized communities specifically, of course, many of the issues they have to deal with are fundamentally political, economical, social, etc., also related to discrimination, of course. But as a psychiatrist or a mental health provider, is there anything that you can do to help those people? And are there specificities when it comes to working with them?
Yeah. Well, I think there are things we can do. Definitely what you're pointing to is something that's sometimes described as a contrast between social structural problems and cultural problems, if you will. And so social structural problems are things like poverty and things like political oppression and things like that just put people in a certain place and say, here's where you are and this is what you're getting and deal with it, and which creates disparities, versus the idea that culture is about beliefs and practices and it implies that you can learn new things and so on. The reality, of course, is these two things are interpenetrating. The structures are maintained by cultural values. The notion of caste or a racialized identity those are cultural constructions. The people are told, if you live in Nigeria, you're not essentially black until you come to North America or Europe. Because everybody around you is, some variation of what you are. That's the background. That's the taken for granted. Suddenly you come to North America and the most important facet of your identity is not what community you belong to or what your religion or this or that. It's your skin color. So you have a new imposed identity. So this is important to understand, that these cultural ways of framing and interpreting each other and the identities we ascribe to each other are part of what creates and maintains social structures that then become kind of brute facts, material facts about people's lives. Can they rent a house? Do they get paid the same amount of money for a job? Do they have the option to get ahead in their career? Very, very basic things in terms of people's well-being. So that's the first point to make. we have to put them both together, though, and we have to pay attention to social structural things. And there's a lot of effort going on right now in medicine and psychiatry to try to complement or expand the idea of cultural competence, that is the ability to notice and pay attention and make sense of cultural differences when they matter to people, with structural competence, that we should understand what it is to be poor, what it is to be racialized, what it is to be a woman in a society that is sexist in certain ways, or what it is to be Muslim in a society where people are extremely anxious and angry about Islamic fundamentalism or something. So those are all structural situations that get created for geopolitical and other reasons that we need to be aware of. Now, often clinicians will say, yes, but those are large political things. That's not I, as an individual practitioner, meeting somebody in my office and trying to offer something, some medicine or some psychotherapy or some family therapy or something. I can't do much with that. It's not entirely true. First of all, people differ in their ability to deal with those structural adversities. So people who are feeling okay and have a big repertoire of skills, interpersonal skills and so on, can navigate those difficult situations better than others. So helping people to navigate those things, learning what works for people, guiding them toward that, toward community resources, toward ways of thinking about things, even being honest with people about the fact that they're up against certain adversity becomes an acknowledgement of that. There's a wonderful book by Claude Steele, a social psychologist, called Whistling Vivaldi, where he talks about internalized racism. And as a black person in the US, when he's walking alone in a neighborhood, whistling Vivaldi, to signal to people around him, I'm a cultivated intellectual person. Don't view me as, this dangerous black man. That's the stereotype that you're getting all the time on mass media and everything else. So on the one hand, it's a sad commentary on, endemic racism and so on. On the other hand, it's an adaptive strategy for someone who has to deal with that. Of course, it cuts both ways, because having to deal with that also means that you're reminding yourself and you're having to deal with that injustice. And so it doesn't erase the burden, but definitely it's a more adaptive way, let's say, than being unaware of how other people might perceive you and not adjusting to that. So that's one set of things that clinicians can share, or can be the mediator, or can recognize. I think there's different levels of advocacy that we also have to engage in. The simplest kind is advocacy on behalf of an individual person we're working with, and making sure that they are getting appropriate responses from the system, where we can influence that on the basis of our professional authority and credentials and so on. But then there's a larger advocacy of educating people, of standing up for social policy and change that will create greater equity. For example, colleagues, Morton Beiser and other colleagues in Canada who studied migration, have shown that, among the most powerful predictors of the well-being of refugees are the reception that they get. So on the one hand, people are very focused in psychiatry on trauma exposure. You saw people die, you experience torture, terrible, terrible things that leave a mark on a person. That has an effect, but actually the most powerful determinant of whether you do well 5 or 10 years later after migration is, what has your reception been in the new society? Are you able to get a job? Are you treated with respect? Are your children able to go to school? In other words, are you able to become engaged in a future-oriented project of improving your life? So those are things that have policy implications. And I think people who do cultural psychiatric research and who document those things, both quantitatively and qualitatively, can go back to policymakers and say, this is what we need to do as a society to have a good outcome, and to offer the same path that has been what happened in previous generations and the big labor migrations of the beginning of the end of the 1800s, the beginning of the last century, when people came under difficult circumstances and in poverty, but actually managed to settle and build lives over 20, 40, 60 years that are very successful. So if we hold that same criteria up for now, one thing it means is we shouldn't be looking at migrants and saying, are you doing well after 5 years? We should be saying, are you doing well after 60 years? See what's happening after a couple of generations. But we should be thinking in terms of social policy about what will make that happen, what will let us, let people build their lives in a way that they really contribute to the society. So I think even though that's well beyond what a doctor or a psychologist would say, that's not exactly my job. My job is working one-to-one or with a small group or a family or something, and I'm going to help them navigate this world. The lessons that we learn from that and the stories that we can share help are resources we can use to try to change policy and to develop more better responses to help people integrate.
So I would also like to ask you, because I talked on the show with anthropologists about this, when it comes to helping people from different cultural backgrounds, particularly perhaps in this case more the ones that come from traditional small-scale societies, for example, we know through anthropology that in different societies they might not have psychiatrists, mental health practitioners, but they have what we could call healers, for example. And there are, for example, those kinds of people, and also community and religious rituals that people can be put through to help them with their mental issues, even though in their particular culture they might not even have the term of or the concept of a mental disorder, but they are in distress or something like that, and people in their own societies can help them. Are there particular cases or situations where even as a psychiatrist you might use those sorts of mechanisms or avenues, like, for example, help talk with, or even if not talking directly, or at least orienting the person to someone in their own particular community that might be equipped to helping them deal with their mental health issue in a way that is culturally appropriate, let's say?
Yeah, absolutely. Well, one of the main interests in cultural psychiatry, we talked a bit about variations in how people express suffering, but another major interest has been in cultural variations in healing practices and helping practices. And this goes back to the earliest, the earliest anthropology, and some people were fascinated with, elaborate healing rituals and so on, which often have a big aesthetic component. There's, lots of things are mobilized to kind of create an important moment for people, a transformative experience in some ways. And so there's been a long tradition of trying to understand that and make sense of what's going on, and to some degree redescribe it in psychological and social terms, which is not meant to necessarily reduce it to that, because people have their own ontologies and their own view of what's going on, but to build a bridge again, to say, okay, we can see what's going on. So a famous effort in that direction is a famous book by Jerome Frank called Persuasion and Healing, where he argued that psychotherapy and ritual healing have the same basic components, that they start with somebody who is demoralized, is feeling discouraged and hopeless and doesn't know how to continue in their life, and they create a special place and time, and they have a designated person who has the healing authority, or who can mobilize the healing authority, because maybe it's a god or a spirit that's going to do the healing, but that person is, helps to mediate that process. There's a person who's designated as the afflicted person, the person who's suffering, and then there's some kind of a set of actions that have symbolic meaning and that are understood by the participants to take them from the state of affliction toward a path of healing. So in that very general, schematic, almost structuralist kind of way, people have said, well, then all healing practices are the same. Of course, yes, at that very broad level, that's true, but then there's lots of detail, there's lots of particularities, and different traditions have their own understanding of what's going on. If you believe your illness was caused by a spirit that's inhabiting the person, and that the spirit has to be exorcised, then you have one kind of action. If you believe it's caused by the person having done something morally wrong, then they have to do some kind of reparation or restitution for that moral. So there are different systems that involve different ontologies. Are there spirits in the world? Is there a moral order that has a profound effect on our minds and bodies and so on? And then sort of collective shared symbols and actions that are full of meaning for people. So as I say, there's a very rich literature trying to understand this and trying to unpack it in different ways. And for me, one conclusion from that is there are actually many different processes. Human beings have many kinds of healing processes. We have physical healing processes. You have a cut, it will heal. That's the image of healing, is very much, you have a wound and there's a natural process of healing. Same thing, psychologically, you're thrown off balance, you're burdened by something, you work it through in some ways. You learn new things, or you adopt a new attitude, and you're somehow able to go forward. So there are different kinds of compensatory processes, and healing rituals and practices mobilize those in ways that make sense to people. when you look cross-culturally, one of the things you see, though, is that often healing rituals are not only about the suffering person, they're very much about their entourage, the people around them, or even the whole community. And in fact, sometimes they're more for the community than they are for the person. There may well be that the person has something that can't be solved, but people may still feel, well, the ritual was helpful because now we understand what the problem is, and now we know what to do, and now things will go better for our family, even if this person is still having a hard time. So that's a bit of a different orientation than typically Western medicine, if I can say that, tends to be highly individualistic, and we tend to separate off the larger context, and particularly the family and community context. So having said that, we have this sort of framework that we've inherited from anthropology and from cultural and psychiatry and psychology that have tried to look at these things that allow us to see many parallels and connections between what we might be trying to do. Even in giving a medication, for example, you can understand that not only as introducing a chemical in the body that has certain physiological effects, but as a symbolic act. If I take an antibiotic, I'm very convinced that I'm now taking powerful medicine that is going to fight off this infection. And that attitude, we know, has significant physiological as well as psychological effects. I mean, there's a whole, as you know, a whole body of work on placebo effects that tells us that whatever else is going on, the symbolic meaning of our actions sets in motion all kinds of things, physiological things, cognitive things, social things that have impact. So having said that, that's the sort of backdrop to the answer to your question in terms of practice. We often encourage people to make use of whatever resources make sense to them. And in particular, biomedicine and psychiatry are not very good at helping people answer the sort of meaning-oriented questions. Why me? Why this? Why now? What's the meaning of this illness? What sense can I make of this? To tell somebody, oh, it's just an accident. It just happened, randomly, or you have a broken brain, or other kinds of crude metaphors. It's a chemical imbalance. These are not very often very meaningful or very satisfying answers for people. So one thing they can get from their own traditions and so on is sometimes an explanation. However, sometimes that explanation is not helpful. This is happening to you because of bad things that you did in the past, and the person doesn't know what those are, and they feel disempowered and invalidated by others. This is happening to you because of witchcraft, and now you're involved in some negative set of social relations. So for that reason, we're cautious. We're open completely in our consultations to people making use of other things, and understand that they may be helpful, but we don't usually prescribe them ourselves because we're not competent to know when and where. We also don't know, just because someone says, oh, I'm Muslim or I'm Christian or whatever, we don't know, oh, you're Christian, you should go for Christian healing. Well, there are many different Christian traditions, and many people would not find, even though the Vatican, I think, still has exorcists, many people would not find that very compatible with their version of Christianity or their engagement. So there's a delicate issue about finding out what matches for the person and what the consequence, and helping them work out what the consequences will be. But the overarching attitude that we bring to this is that it's not either or, and that we're offering resources to people. We're trying to find things that will help. And if they have other resources, or if we can make them aware of other resources that might help them make meaning of their suffering, might help them have social support and solidarity, might give them techniques, of prayer, of meditation, of yogic practices, all kinds of things that are more and more being assimilated into the repertoire of psychological practitioners, in fact, but that might exist within your tradition. I don't need to send you to do mindfulness-based cognitive therapy if you already practice that as part of your tradition. I'll just remind you that maybe this could be helpful as one thing you can add to your dealing with the stress that you're having from what you've lived through. So that's the general picture, and I think it varies from case to case, and we try not to be heavy-handed about it, and try not to create either-ors for people where they feel like either I do this or I'm showing, if I go to this traditional thing, I'm not being modern and sophisticated, and I'm going to be derided by my doctor, and so on and so forth.
Mm-hmm. And I would imagine that this is a very delicate line to thread, because on the one hand, we know that, for example, certain religious practices certainly have positive psychological effects on people and might help them deal with certain psychological issues, they're dealing with. But on the other hand, we also know that particularly certain religions, certain religious practices and contexts, and I'm focusing on religion here, but I could be focusing on other cultural aspects as well. But we know that historically and even contemporarily in certain communities, people with certain, for example, gender identity, sexual orientations, and so on, things about their psyche that they can't really change or have control over might be demonized, ostracized, stigmatized, and so on. And that might also lead to more severe mental health outcomes, and that might also be a reason why they seek help with psychiatrists and other
Yeah.
mental health providers, right?
No, you're absolutely right, and I think it is delicate. And underneath it is a sort of a shift in orientation. I think early on, culture is a category that came out of colonialism, and it was, a kind of looking at other peoples and with an implicit hierarchy that, Northern Europeans are at the peak of cultivation and other people are somewhere on the path. And then, I guess, partly as a reaction to that, there was this almost romantic view that every culture is its own world and everything is perfectly balanced and adjusted, and we shouldn't tamper with it, and it all makes sense. And so that kind of overly idealized view and static view in some ways has imposed itself on the view of traditional healing. So people will say, oh, that's their tradition. They know how to solve these problems. It works fine. Or you will often hear, oh, they've used that kind of medicine for thousands of years, so it must work. People do all kinds of things for thousands of years that are not necessarily optimal. Not everything works out that way. Things persist for other reasons, including that they advantage one group even though they disadvantage another. So the realistic view, I guess, is that cultures are in motion, that things are not perfect, that some things are helpful, some things are not. There's usually trade-offs, and that's the way I often look at it. Is I'll say, so what's the trade-off here? Here's a benefit and here's the drawback, and that you can apply that to any medication we give. We call the trade-off side effects. This has a beneficial effect, but it has a harmful effect. Same thing for other things people might do. We're going to do bloodletting. It has a beneficial effect. It has a harmful effect. We're going to do prayer. Well, maybe it has a beneficial effect. It has a harmful effect. It depends what the prayer is and what position it puts you in vis-a-vis your own agency and your own position in society. So not that we can either also put ourselves in a sort of omniscient position where we can truly weigh that, but at least to be open to that and to be reflecting on that with the people we're working with and help them navigate those things to see what the trade-offs are in the things that they're trying. That's why I say we try to avoid this either or, because the underlying assumption is nothing's perfect. Things might have some benefit, but they probably will also have a cost, and we might not fully know that. And I say that applies to doing psychotherapy or family therapy or giving medication or anything else we do, and it equally applies to any particular form of traditional healing. So can we look at that with people and accompany them through that process as they try to make sense of what's working with them, and try to make available to them the range of things that are useful to them and fit with their own expectations and their own ability to make use of things. Because whatever we offer, particularly if we offer forms of psychotherapy, which encourage people to think about themselves in a different way and to act in a different way, those are especially effective when they fit with the world around you. If I go to a psychoanalyst and I get a story about my upbringing and how it affected me, I have certain friends I can go to talk about that, and they'll really appreciate the story and they'll share their own version of that story. But I could be a first generation migrant where I go and do that and I come home and talk about it and people are just scratching their head or they're just taken aback. How could you talk about that? How could, the point is equanimity, or the point is filial piety, respect for your elders, or whatever. I mean, different value systems that don't necessarily jibe at first pass with that particular narrative of the self that is being offered as a way to navigate the world.
Mm-hmm. So we've already talked about migrants, minorities, a little bit also about refugees. I would like to ask you now, what are some of the main challenges of cultural consultation work in rural and remote communities?
Well, we have this in the Canadian context. What that largely means in our case is Indigenous peoples, because we have 4 or 5% of the population of Canada are people of Indigenous background, and a substantial portion of them still live in relatively remote communities and have limited access to professional resources. So the most basic issues are structural in the sense that a lot of the things that we might offer in mental health, like somebody to talk to over a long period of time to make sense of your life, to put psychotherapy in the sort of simplest terms, most basic universal terms, somebody who bears witness to your suffering and says, tell me more, I'll stick with it and I'll try to understand, which, is helpful to many people in many different backgrounds. That's not readily available in many places because it's a tiny community and there's no one there physically present. And the people who might be there are closely related to you. So they don't have the requisite distance to listen to your suffering without it becoming their suffering in a way that then interferes with you dealing with your issues. So that's a basic structural problem. The other structural problem for many of those communities is some of the adversity and the difficulties they're facing are built into that geography. They're built into that predicament in terms of how the world is sort of going. I should say that social networking, that internet and communications technologies are really changing that to some degree, that they're allowing new kinds of connectivity for better and for worse. I mean, for young people, it cuts both ways because they also see a larger world out there that then is quite at odds with the immediate realities that they face, and that can create tensions and disappointments and so on for people. But in terms of connectivity, in terms of sharing knowledge, in terms of possibilities at that level, I think there are lots of potential for that to develop. And the other thing is, because resources are limited, there's a tendency to approach things with a lowest common denominator. Okay, well, let's give pills because that's easy. We have published a paper in our journal years ago by Sumit Jain and Sushil Jadhav on Indian community mental health policy called Pills That Swallow Policy. Because the policy was to have community mental health with a big range of options for people. But the reality is that the mental health practitioner, psychiatrist, comes to a village and is there for a half day and has to see 50 or 100 patients. So what can they do? They can, say hello and write a prescription and see the next person. So in other words, because of a structural constraint, you end up with a very simple and potentially harmful approach in which you're not really engaging with people in depth. And then I guess the deeper level is what we've been talking about already, which is what my colleague Joe Gahn, as an indigenous psychologist, anthropologist, has talked about as cultural proselytization. That ostensibly we're offering the best available scientific understanding of how the mind works and how to adapt. But at the same time, we're offering a value system. We're offering a set of implicit goals, a way to live life. And we know already that there are flaws with that being achievement-oriented and materialistic and driven is not necessarily a recipe for health and well-being. And that we're suffering a lot in urban industrialized societies with all of the consequences of that kind of orientation to life, whereas people who are able to orient their lives toward aesthetic values, toward solidarity and connection, toward creativity, toward relationships and so on, have probably better mental health as a result, because those are intrinsically rewarding activities that human beings need for their own well-being. So we have to, I say that's the challenge, is that the lack of self-critical awareness within our disciplines that doesn't open up an adequate space to have the important conversations and reflections that have to occur, so we don't just impose what we say is the best. You're getting up-to-date care because we're giving you the newest medication, but in fact is not serving people's needs properly.
Mm-hmm. So I have two more questions. The first one is, so we've already talked about how we have to take cultural context into account when making clinical assessments, when trying to helping people, in this case, with their mental health issues and so on. But can culture also influence how mental disorders manifest themselves and the impact they have on people's lives?
I think they can. I think this brings us to sort of this, what's sometimes framed as this sort of basic question of sort of cultural relativity. To what extent do cultural differences really lead to people being fundamentally different in their constitution and their ways of being. And it's a complicated issue because there are many, many commonalities among all human beings, very basic commonalities, not only physical ones in that we're all physically constructed roughly similarly, but existential ones. We all are mortal. We all face this existential predicament of some point realizing that are mortal and not necessarily liking the idea. So, we are all born in some kind of a family, and we are early on very, very dependent on the care of other people around us, and we're constructed in such a way to make those relationships of dependence central to our early development. So there are all these sort of things that are both biological and, as I would say, existential, that are part of our shared humanity. At the same time, every single person is experiencing that in a particular way because of the history of the place and time where they are. So the language that they're exposed to, the visual environment that they're exposed to, and so on. So something as basic as, the perceptual illusions of the Mueller-Lyer arrows, that depends on being in an environment in which you have corners all the time and you're learning to judge, heights from looking at square buildings. If you live in an environment with round buildings, you don't show that illusion to the same degree. So culture is shaping, in other words, your basic sensory perceptual processes developmentally from very early on. And we could say that culture in that sense is rewiring your brain to some degree. We think any infant born anywhere can learn any language, but it starts in utero that the brain is being tuned to certain phonemes and is learning to make certain distinctions and not learning how to make others. And so then later on we try to learn language and we have an accent and we can't get rid of it because we don't even hear it in a way. It just sounds, it's the way it is to us. So those are just crude examples of this tuning that's going on all the time in different ways. There's no reason to think that wouldn't also be affecting things like how we regulate emotions, for example, or how we negotiate certain interpersonal processes in a way. And it was very high level functioning things that are the kinds of things that seem to go wrong when we have mental health problems. So even though there are broad similarities, and we can say, look, there are people everywhere in the world who have illnesses in which they start having auditory hallucinations, and they hear voices talking to them, and that becomes disruptive to them. Yet we know from the work of Tanya Luhrmann that the kinds of voices people hear in different parts of the world are very different. And in North America, those are usually critical voices of others talking about you. And in other parts of the world, in India and Africa, often they are familiar voices and they're not saying negative things to you. You can imagine what a difference that makes in terms of your well-being. So you can say on the one hand, there's a universal propensity human beings have to maybe this related to our auditory system and internal language and how we decide what is coming from us and what's coming from outside and some very basic processes. But the actual form it takes and the consequences in terms of our sense of well-being and how persecuted we feel and so on is going to vary based on culture. So that's the point I guess I'm trying to make, is that it used to be thought that there were some very particular kinds of problems that only occurred in certain parts of the world, and we talk about culture-bound syndromes. We've tried to avoid that term lately, first of all, because cultures themselves are no longer, if they ever were, that bound, that there's all this movement and circulation going on, so it's a bit of an illusion, but also because every illness, every problem is an interpenetration of universal biological, psychological, and existential processes and particular cultural processes. So to take an example that I've used in the past, in Japan in the 1920s, people identified a kind of anxiety, a kind of social anxiety, in which people were very afraid of offending other people. And unlike the social anxiety that was talked about in Europe and North America, where people were very afraid of being embarrassed in front of other people, this had the same element of embarrassment, but it also had this notion: I'm going to offend you. I'm going to offend you by blushing, or I'm going to offend you by staring at you, or I'm going to offend you by having a bad body odor. And the preoccupation was with offending other people. So that got called Taijin Kyofusho, sort of interpersonal phobia, and it was viewed as a Japanese culture-bound syndrome. So we now know that there are other places where this occurs, and it occurs sporadically everywhere because people have a mix of feelings in those situations. People have feelings of, yes, I'm very ashamed and embarrassed and want to avoid, performing badly in the situation, but I may also be concerned that I'm making other people uncomfortable. And what's going on there is a way of configuring the self that then shapes which symptoms you focus on. So the general view right now would be that not that there are radically different mental health problems, but that the particular ways that things go wrong is shaped in some ways by interpretive processes, by past learning, and by the social context that people are in. So Devin Hinton, for example, is a psychiatrist and anthropologist who's cataloged a bunch of different kinds of panic attacks that depend on culture-specific beliefs. So we could say there's a universal propensity to have panic attacks in the sense that if you get very frightened and you start hyperventilating, you can drive your blood chemistry in such a direction that you start having more symptoms and feel more anxious. So that's a physiological loop that's going on that every human being has the potential for. But some of the people that he's worked with from Southeast Asia believe that when you start feeling dizzy, it's a sign that you're going to have a stroke. And so they have orthostatic hypotension-induced panic attacks. Somebody stands up quickly, feels dizzy, and has a panic attack because of a cultural particular belief. So you can say, again, there's the universal potential loop, but the particularity of the process depends on this explanation. So that's a more common model these days about how we would think about how culture penetrates into some basic processes that might be identifiable across very different cultures and contexts.
Mm-hmm. So one last question then. How important do you think is the role that the social sciences, like, for example, anthropology, sociology, cultural psychology, for example, but also other branches of psychology, have to play in or can play in medicine and psychiatry more specifically? Because, of course, we are used to psychiatry and medicine in general having all sorts of guidelines and medication and psychotherapies and all of that are based on randomized controlled trials and meta-analysis and all of that. And of course, that's all absolutely fine. But on the other hand, it seems to me that doctors and medical professionals are perhaps not paying too much attention to the work that's done in the social sciences, anthropology more specifically, because there are certain practices, particularly when it comes to mental health and mental health outcomes, that we find across different societies and cultures and cultural contexts that work, even if sometimes it's just placebo, they still have positive psychological effects. And many times people, because they have too much of a, let's say, scientific mindset, very easily dismiss some of those things as superstition or irrational things or something like that. But perhaps we shouldn't, right?
Yes. Well, I mean, I wouldn't set science in opposition to that. I would set scientism in opposition to that. In other words, the belief that a particularly simplified version of science already gives us all the answers already, which no scientist would ever want to say. Scientist is not about. It's not about that. It's about having an inquiring mind and thinking critically. So, and that's where I would say the social sciences and philosophical critique and so on play an absolutely vital role, which is that, this is a point that the anthropologist psychiatrist Arthur Kleinman made years ago. He talked about the category fallacy. We have a set of categories for the world, and we see the world through those categories. So we have a set of categories for mental illness, and we see the world through those categories. And it doesn't mean those categories are useless, but it means that since we're looking through those things, that's all we see. We don't see all the things that are, for that moment, in the periphery for us. And yet for other people, those things might be in the center. So we have to step back from our categories. How are we going to do that if we have to use some kind of categories to structure all the complexity of the world? Well, it's partly by comparative methods. It's by trying on another pair of glasses. It's by looking at it from another way and taking enough time to do that genuinely, to do that with some depth. And in the process, we not only develop a language for talking to other people and seeing the world a little bit from their point of view, we really enlarge our range of possibilities. It doesn't mean we can't go out and do randomized trials and say, okay, so, or ask questions, how does this work? You know, you say it's God, but maybe I want to understand some component, how God's acting. Maybe God's acting through serotonin this time, or God's acting through a cognitive process. I want to unpack that in a way because that will allow me to know when and where can I generalize this if I'm going to work with something else. So that's worthwhile. But do I even have the right bits of the right questions, the right bits of information on the table to ask an intelligent question? Because if I'm already having this highly simplified view, like if I think depression is just about too much or too little of a chemical, then maybe I'm missing the fact that it's actually about brain circuitry, and that brain circuitry is actually learned in relationship to other people. And the purpose of brain circuitry is navigating a social world, so that the actual picture of what's going on has to be something much larger than a chemical imbalance, that was the wrong level of description of what's gone wrong and going to lead to the wrong approach to making things better. So again, for me, I don't want to set it up as an either or, like we just have to take everything that comes from every tradition on face value and say, oh, it's because it's venerable and because it's deeply felt and held by people, it's sacrosanct. I think we live in a cosmopolitan world. We're entitled to ask questions and to think about it, and people from within traditions have questions, so we want to be able to do that. But we need to do it with the right information on the table, not with looking through this keyhole and saying, I think I know everything I need to know about this now, and be missing things. So that's why a lot of my effort lately with people has been trying to write about a more, we're calling it now cultural eco-social, a kind of cultural and ecological way of understanding what the human being is, and for that matter, what the brain is. I mean, the brain is the organ of culture. The brain is the special thing we have for navigating social worlds, and it can go wrong in different ways that reflect exactly that task that it has of helping us, live with each other and cooperate and deal with conflict and so on. So if we have that big enough view of what's going on, it leads us to a different kind of science, to a different kind of biology. It's not a reductive biology. It's, there's interesting work now in systems biology. Dennis Noble's a great exemplar of that in terms of his writing about the idea that in biological systems, causality can start anywhere. So in human systems, my mental health problem might start with my problems in my family. And the right level of causal description is not about the chemicals in my brain, it's about the conflicts in my family. It has effects on my brain, but the right, the most useful way of describing what's going on might be at that level. So we're trying to articulate that as a rigorous framework, in a sense, that can be studied empirically, that can be used to integrate different points of view. And what it leads to is very much a deep interest and respect for the great variety of ways of life, of experiments, of creative things that have happened in traditions. And I will say that you see this very clearly right now in contemporary psychology and psychiatry, in the embrace of mindfulness and compassion-based interventions that have their origins in meditative traditions, in Buddhist and other meditative traditions. And so how were those arrived at? They were arrived at empirically, I would say, by trial and error and by so on, but they weren't arrived at by classical scientific methods, as it were, and yet they're amenable to study and so on. But that study, again, has to not look for what's the molecule that's doing this, because that's the wrong level of description of the process that we're trying to understand.
Mm-hmm. Great. So I'm leaving a link to the book in the description box of the interview. Again, Cultural Consultation, Encountering the Other in Mental Health Care. Dr. Kirmayer, just before we go, would you like to mention where people can find you and your work on the internet?
Yeah, you can find me in, ResearchGate and Academia EDU, and just Googling around, you won't have any trouble finding our website at McGill, where we have an annual summer school where we talk about these things. There are two other books that I've alluded to. One is called Revisioning Psychiatry, which talks more broadly about this framework, and then a recent book called Culture, Mind, and Brain, which really talks about how those are put together. So again, those are not hard to find. And there are a bunch of videos out there. We did a summer school. I do a summer school course every 29 years now in cultural psychiatry, and I think the 2012 version of the lectures are out there you can watch. So anybody who's curious, I encourage you to look into it more. There's a meeting coming up. Makes it very time focused now, but at the end of April, there's a joint meeting in San Diego of the Society for the Study of Psychiatry and Culture, which is and it's a joint meeting with the Society for Psychological Anthropology, which I'm currently the president of. So it's two groups, one very anthropological, one very clinical, who have common interest and are actually getting together for the first time in the same place. So encourage people who are interested to come join us.
Okay, great. So I will be leaving also some other links to your work in the description box of the interview. And Dr. Kirmayer, thank you so much for taking the time to come on the show. It's been a real pleasure to talk to you.
Been a pleasure for me too. I really appreciate it. Thank you so much.
Hi guys, thank you for watching this interview until the end. If you like what I'm doing and to keep the channel sustainable, please consider supporting it on Patreon or PayPal. The links are in the description box of this interview. And if you like this interview, please share it, leave a like and hit the subscription button. This show is brought to you by Enlights, Learning and Development Done Differently. Check the website at enlights.com. I would also like to give a huge thank you to my main patrons and PayPal supporters, Karen Litzke, Blanchett Perga, Larsen, Jerry Mueller, Hans Frederick Sunda, Bernardo Seixas, Herbert Gintis, Olaf Alex, Jonathan Visser, Adam Kessel, Matthew Whittingbird, Arno Wolf, Tim Hollacy, Henrik Alenia, John Connors, Philip Force Connolly, Dan Demetrio, Robert Windiger, Rui Inácio, Zup, Marco Neves, Colin Holbrook, Simon Columbus, Phil Kavanagh, Jorge Spinha, Michael Stormir, Samuel Andrea, Francis Fort, Tiago Nunes, Alexander Dunbauer, Fergal Cusson, Harl Herzog, Nuno Machado, Jonathan Librant, João Linhares, Stanton T, Samuel Correa, Eric Hines, Mark Smith, João Eira, Tom Hummel, Sardas France, David Sloan Wilson, Yacila Dez Araújo, Romain Roach, Diego Londonho Correa, Yannick Punter, Adana Rusmani, Charlotte Bliss, Nicole Barbaro, Adam Hunt, Pablo Stazewski, Nelek Bach, Guy Madison, Gary G. Hellman, Saima Afzal, Adrian Yegi, Nick Golden, Paul Tolentino, João Barbosa, Julian Price, Edward Hall, Edin Bronner, Douglas Fry, Franca Bortolotti, Gabriel Pons Cortez, Ursula Litzke, Scott Zachary Fish, Tim Duffy, Sonny Smith, John Wiseman, Morton Eichland, Dr. Bird, Daniel Friedman, William Buckner, Mau Maria, Paul George Arnaud, Luke Lowacki, Georgios Theophanes, Chris Williamson, Peter Wolozin, David Williams, Ruth Towell, Diogo Costa, Anton Erickson, Charles Murray, Alex Shaw, Amaury Martinez, Coralie Chevalier, Pedro Bonilla, Ziegler, João Barbosa, Bangalore Atheists, Larry D. Lee Jr., Old Herringman, Sterry, Michael Bailey, Dan Sperber, Robert Grassis, Tom Roth, DRPMD, and Igor N. And special thanks to my producers, Izar Webb, Jim Frank, Lucas Tafinia, Tom Vanagdam, Bernard Hugney, Curtis Dixon, Benedict Mueller, Vega Guidi, Thomas Trumbull, Catherine and Patrick Tobin, John Carlo Montenegro, Robert Lewis, and Alnick Ortiz, and to my executive producers, Michel Rugieski, Matthew Lavender, Sergio Quadriano, and Bogdan Kanivets. Thank you for all.